Hi everyone, let's talk about acute kidney injury or AKI. So just here for reference, I have a picture of glomerulus, which are these tiny microvascular bundles all throughout the kidney that help to filter, and we're going to talk about some of their pathologies as well. So when you're thinking AKI, it's because of a sudden increase in the BUN, so the blood urea nitrogen, and creatinine. So the first question you have to ask yourself is this kidney hypoperfused, i.e. is it pre-renal? So hyperperfusion happens when all the fluid that would go to the kidney is leaking out into the interstitium, so pathologies like heart failure or cirrhosis. Is the patient just dehydrated, or is there some sort of vascular blockage like renal artery stenosis or in young women, fibromuscular dysplasia? So the diagnosis besides clinical is also made with a BUN creatinine level that's over 20. And that's because the kidneys are pulling the BUN back into the bloodstream to reduce what they're perceiving as water loss. Other useful labs include urinary sodium, FeNA, and Phe-urea levels, and I suggest you read more about that. So for the treatment, you want to get fluid to the kidney. If these patients are fluid overloaded, like heart failure, you give them diuretics, and if they're dehydrated, you give them fluids. Now, if it's not pre-renal, be thinking about post-renal, so some sort of obstruction. So here, maybe the prostate is enlarged, or you have kidney stones, which ultimately is causing backup of the urine into the kidney itself, so you want to diagnose with imaging. So ultrasounds will show if there's hydronephrosis, but if you're thinking stones, use CT. The BUN creatinine level isn't overly helpful because it's normal. In terms of treatment, you want to clear the obstruction, so that depends on the pathology. But for temporizing measures, you can use a Foley if the block is below the ureters and a nephrostomy if the block is above them. So if it's neither pre or post-renal, you should be looking into the kidney itself. And there's a lot of different pathologies that can lead to intra-renal. I like to think about them all being structural. You diagnose these usually with urinalysis before treatment. Biopsy is definitive. It's not always necessary. And if you're asked about BUN creatinine levels, they're very low. And the way I like to think about it is if the kidney is broken, it's not going to reabsorb. So it doesn't reabsorb BUN, and the treatment is based on the type. So let's get into those. So understanding the types is understanding the functional unit of the kidney, which is known as the nephron, right? So this pink area inside the box is the interstitium, which is embedded with a series of tubules which collect and concentrate the urine, and those are intimately associated with the glomeruli, the vascular system that supplies the blood for filtration. So if we're thinking about inside of the kidney being injured, we try to rule out things like tubular, which clinical history is going to tell us a lot. These are patients that are going to either have some sort of ischemic event, so like a traumatic event where there's blood loss, or some sort of clog that's happening due to this huge release of hemoglobin and myoglobin. So you can be thinking about things like rhabdomyolysis, seizures, or hemolysis. And importantly here, people with sickle cell trait are at very high risk for tubular necrosis, acute tubular necrosis, so you want to keep them well hydrated. Basically, the diagnosis here is urinalysis that shows things like muddy bronchitis, what I call RBC-free hematuria, so a lot of free hemoglobin, myoglobin, but no cells in that UA, very high creatinine, and very little urine. So you treat these people with supportive care IVF. If it's not inside the tubules, is it something wrong with the glomeruli? So glomerulonephritis. So there's a whole lot of etiologies here. And we'll go into these a little bit because it's nice to have a differential list to tell your attending. And also it's a good thing for step one. So the way I like to remember this is Army GP. So Alport's, rapidly progressing glomerular sclerosis, membranoproliferative, IgA or Berger's, good pasture, or post-streptococcal GN, glomerular nephritis. So I like to remember what they are caused by pairing Alports and good pastures. So I think about Alports as Alforts because it is due to an anti-collagen 4 antibody. Likewise, good pasture is due to glomerular basement membrane antibody. So Alforts is with 4 organ involvement. So the kidneys, the lungs, the eyes, and the ears. Good pasture is relatively good to have because it only involves the lungs and the kidneys. So it's really not that great, but at least it's not the eyes and ears. RPGS is really bad because it's rapidly progressive. So I like to think about this as rapidly crescentic because it makes the crescents in the histology that you see. Membranoproliferative oftentimes is associated with hepatitis, and IgA is post-infective. So if you see somebody with a URI or a UTI, and they come in and they have basically linear depositions of IgA on biopsy. That's what you're thinking is IgA, not to be confused with PSGN, which is specifically streptococcal, and that can either be pharyngitis or your skin infections. So you diagnose all of these with urinalysis. And like I said, a biopsy is definitive. And a nice rule of thumb here is that the treatment can be steroids, but that's really disease dependent. So if we're not thinking it's tubular, if we're not thinking it's the vascular component, then we have the interstitium left. So is this acute interstitial nephritis, or what I like to call allergic nephritis? And the reason being is because these patients have been exposed to some sort of quote unquote toxin. So in some cases it might be contrast. So you need to give your patients a lot of fluid before contrast. Or is it some sort of antibiotic to which people normally have allergies, like penicillins or sulfa drugs? Or maybe NSAIDs, which in addition to causing this AIN, also constrict the afferent vessels. So here the diagnosis is made with these white blood cell casts you see in urinalysis. Those are actually eosinophils, but we can't tell they're eosinophils in a urinalysis. So more definitive is following a biopsy, you can do a Hansel-Wright stain. The treatment here is to ultimately stop the irritant, and it will be self-resolving. And if it's refractory to anything, give them steroids. So if we have that patient that has the acutely elevated BUN and creatinine, we're worried about AKI, right? So look at your patient. Are you thinking that this patient is fluid overloaded, dehydrated, or have they had this history of this weird high blood pressure because of renal artery stenosis or fibromuscular dysplasia? Then you want to look at the BUN and creatinine because that should be really high if it's pre-renal, right? You hydrate those people with either diuretics or fluids. Now, if you're thinking obstructive, like a big prostate or stones, you want to do imaging, urinalysis, or in the case of stones, CT, to assess for that obstruction and clear the obstruction. If it's neither pre or post-renal, it's probably inside the kidney itself. So you want to do a urinalysis. So if you're seeing a patient who has ATN, you're usually thinking muddy brown casts or something that looks like hematuria but no cells on the UA, right? This is following things like rhabdo or seizures. You want to hydrate those patients. If you're seeing something like a glomerulonephritis, this is also hematuria. Here, biopsies really help a little bit more. We talked about Army GP for the types of etiologies. Sometimes steroids help, not always. It depends on that etiology. Finally, we have interstitial, right? We called this the allergy because it's a response to your typical allergic antibiotics, your NSAIDs, or contrast. Stop giving those. It should be self-limiting. All right, guys, great job and good luck studying.